Welcome to Pediatric Case Review, Musculoskeletal System Series. Today's lecture is a comprehensive case-based review of acute osteomyelitis in children, designed for general pediatricians preparing for clinical practice and board examinations. We will cover 15 carefully crafted clinical scenarios exploring the presentation, diagnosis, imaging, pathophysiology, antibiotic management, and complications of this important pediatric bone infection. Let us begin. Case 1. A 4-year-old boy presents with 3 days of right leg pain and refusal to walk. His mother reports a low-grade fever of 38.2 degrees Celsius with no history of trauma. On examination, there is tenderness over the right lower limb with mild swelling but no redness. Which of the following is the most likely diagnosis? Option A, transient synovitis. Option B, stress fracture. Option C, osteomyelitis. Option D, leg-calf-Pertus disease. The correct answer is option C, osteomyelitis. This 4-year-old presents with the classic triad of acute osteomyelitis: limb pain without a trauma history, refusal to bear weight also called pseudoparalysis, and low-grade fever with systemic upset. Transient synovitis typically affects the hip, is afebrile, and resolves spontaneously. Stress fractures follow repetitive overuse activity. Leg-calf-Pertus disease has an insidious onset over weeks to months without fever. The metaphysis of long bones, particularly around the knee and proximal tibia, is the most common site of acute osteomyelitis in school-age children. Case 2. A 2-year-old girl is brought to your primary care clinic. Her mother reports 2 days of fussiness and refusal to put weight on her left leg. She was previously healthy and walking normally. There is no history of trauma or fever. On examination, the child cries when you attempt to examine the left lower extremity. You note mild tenderness over the proximal tibia with no swelling, warmth, or erythema. Vital signs are normal. What is the most appropriate next step in management? Option A, discharge home with reassurance and follow-up in 1 week. Option B, order plain radiographs of the left leg. Option C, initiate empiric oral antibiotics immediately. Option D, refer urgently to pediatric orthopedics. The correct answer is option B, order plain radiographs of the left leg. Plain radiography is the first-line imaging investigation in any child with suspected bone pathology. Its primary role is to exclude fractures and other bony abnormalities rather than to confirm osteomyelitis directly. In early osteomyelitis, the bone appears completely normal on plain film because periosteal reaction and lytic changes only become visible after 7 to 14 days of infection. Soft tissue swelling may be the only radiographic finding in the first week. This makes plain radiography a screening tool, not a diagnostic one for early disease. A normal X-ray absolutely does not rule out osteomyelitis in the first week of illness. Case 3. A 6-month-old infant presents with 3 days of irritability, poor feeding, and refusal to bear weight on the left leg. Parents report the child seems uncomfortable when the leg is touched or moved. Temperature is 38.1 degrees Celsius. Physical examination shows tenderness over the proximal tibia with mild swelling but no redness. Plain radiograph shows no fracture or obvious bony changes. Magnetic resonance imaging reveals abnormal signal intensity in the proximal tibial metaphysis with surrounding soft tissue edema. What is the most likely diagnosis? Option A, transient synovitis. Option B, non-accidental trauma. Option C, acute osteomyelitis. Option D, septic arthritis. The correct answer is option C, acute osteomyelitis. In infants and young children, osteomyelitis frequently presents with nonspecific signs. Irritability and poor feeding are the predominant complaints, and fever may be absent in up to 50% of neonatal cases. Pseudoparalysis, meaning the infant refuses to move or use the affected limb, is the most important clinical clue. Subtle swelling without erythema is common. Infants are also at high risk for multifocal osteomyelitis, so a thorough full-body examination is essential when this diagnosis is suspected. A high index of clinical suspicion is required because the presentation can mimic colic, feeding difficulties, or non-accidental injury. Case 4. A 6-year-old girl presents with left leg pain for 4 days after a playground fall. She is afebrile but refuses to bear weight. Examination reveals localized tenderness over the proximal tibia with minimal visible swelling. The overlying skin appears normal with no redness or warmth. Which physical examination finding would most strongly suggest osteomyelitis rather than a soft tissue contusion? Option A, presence of localized swelling. Option B, pain that worsens with passive movement. Option C, point tenderness directly over the metaphysis. Option D, decreased range of motion at the nearby joint. The correct answer is option C, point tenderness directly over the metaphysis. Metaphyseal point tenderness is the hallmark physical finding of pediatric osteomyelitis. The metaphysis is the zone of rapid bone growth with a rich vascular sinusoidal network where blood flow is sluggish, making it the preferred site for bacterial seeding. Pain on direct palpation of the bone at this specific location is often out of proportion to the visible signs and may be the only abnormality present in early disease. This distinguishes osteomyelitis from joint pathology, which produces effusion and restricted range of motion. The clinical rule to remember is metaphyseal tenderness plus refusal to bear weight equals osteomyelitis until proven otherwise. Case 5. A 5-year-old boy presents to the emergency department with a 2-day history of right hip pain and limping. His temperature is 38.5 degrees Celsius, and he appears uncomfortable. No trauma is reported. On examination, the child resists all passive range of motion of the right hip with significant pain on internal and external rotation. There is no visible swelling or erythema over the hip. Which of the following is the most likely diagnosis? Option A, transient synovitis. Option B, septic arthritis. Option C, osteomyelitis of the proximal femur. Option D, Legg-Calvé-Perthes disease. The correct answer is option B, septic arthritis. This child meets at least 3 of the 4 Coker criteria: fever above 38.5 degrees Celsius, complete non-weight bearing, and resistance to all passive range of motion of the hip. When 3 or more Coker criteria are present, the probability of septic arthritis exceeds 93%. Osteomyelitis of the proximal femur typically produces metaphyseal point tenderness and preserved range of motion until late in the disease course. Transient synovitis is afebrile or minimally febrile with normal inflammatory markers. A critical teaching point: in infants under 18 months, osteomyelitis and septic arthritis can coexist because transphysial blood vessels allow infection to spread across the growth plate from the metaphysis directly into the joint. Case 6. A 5-year-old girl presents with 4 days of right knee pain and limping. She is afebrile and appears well. Examination reveals mild swelling around the knee joint with limited range of motion due to pain. Laboratory studies show a normal white blood cell count and mildly elevated erythrocyte sedimentation rate. Which of the following findings would be least consistent with a diagnosis of osteomyelitis? Option A, presence of joint effusion on ultrasound. Option B, tenderness directly over the bone metaphysis. Option C, pain that worsens with passive range of motion. Option D, normal appearance on plain radiographs. The correct answer is option A, presence of joint effusion on ultrasound. Isolated acute osteomyelitis typically does not produce a significant joint effusion because the infection is confined to the bone and periosteum rather than the joint space. When a joint effusion is identified on ultrasound in the context of suspected bone infection, it should raise concern for septic arthritis or a combined infection involving both bone and joint. Metaphyseal tenderness is the hallmark of osteomyelitis and supports the diagnosis. Normal plain radiographs are entirely expected in the first 7 to 14 days. Ultrasound is a useful bedside tool to identify effusion and guide aspiration when the diagnosis is uncertain. Case 7. A 3-year-old girl presents with a 2-week history of persistent limping. Her parents report she favors her right leg and is reluctant to run or climb stairs. There is no trauma or recent illness. On examination, she appears well and afebrile. Gait assessment reveals an antalgic limp with a shortened stance phase on the right. There is decreased range of motion at the right knee with mild tenderness over the proximal tibia, but no swelling, redness, or warmth. Neurological examination is normal. What is the most appropriate next investigation? Option A, order plain radiographs of the right leg. Option B, discharge with reassurance and follow-up in 1 week. Option C, obtain magnetic resonance imaging of the right knee and tibia. Option D, start empiric oral antibiotics immediately. The correct answer is option C, obtain magnetic resonance imaging of the knee and tibia. In a child with persistent limping lasting 2 weeks and localized bony tenderness, plain radiographs should be obtained first as a screening step. However, when clinical suspicion for osteomyelitis remains high despite a normal plain film, magnetic resonance imaging is the gold standard next investigation. Magnetic resonance imaging detects early marrow edema and subperiosteal collections within 24 to 48 hours of symptom onset, with a sensitivity approaching 95%. It can differentiate bone marrow infection from soft tissue inflammation, cellulitis, and abscess. Gadolinium contrast enhances diagnostic accuracy and helps identify collections requiring surgical drainage. Case 8. A 3-month-old infant presents to the emergency department with a 2-day history of irritability and poor feeding. The mother noticed the baby will not move his right leg normally. There is a low-grade fever of 38.1 degrees Celsius and no history of trauma. On examination, the right thigh appears swollen compared to the left. The infant cries when the right leg is touched or moved. There are no skin changes or wounds. Magnetic resonance imaging reveals bone marrow edema in the proximal femur extending across the growth plate into the epiphysis. What anatomical feature best explains this pattern of infection spread in infants? Option A. Thinner cortical bone allowing easier bacterial penetration. Option B. Presence of transphysial blood vessels crossing the growth plate. Option C. Immature immune system with poor bacterial clearance. Option D. Higher metabolic activity in growing bone tissue. The correct answer is option B. Presence of transphysial blood vessels crossing the growth plate. In infants and children under 18 months of age, specialized blood vessels called transphysial vessels pass directly through the growth plate, connecting the metaphyseal circulation to the epiphysis. These vessels provide a direct anatomical pathway for bacteria to bypass the epiphyseal cartilage barrier and spread from the metaphysis into the epiphysis and potentially into the adjacent joint. This explains why osteomyelitis in young infants frequently presents with simultaneous joint involvement and why the hip and shoulder joints, whose metaphyses are intracapsular, are at particular risk. After approximately 18 months of age, these vessels regress completely, making the growth plate an effective barrier to infection spread. Case 9. A 1-year-old child is diagnosed with acute osteomyelitis of the distal femur. Imaging shows involvement extending into the epiphysis. Which anatomical feature most likely allowed the infection to cross the growth plate? Option A. Cortical bone thickness. Option B. Epiphyseal cartilage seal. Option C. Transphysial vessels. Option D. Periosteal blood supply. The correct answer is option C. Transphysial vessels. This question reinforces the critical age-dependent anatomy of pediatric bone infection. In infants and toddlers under 18 months of age, transphyseal vessels cross the physis and provide a direct vascular channel for bacterial spread from the metaphysis into the epiphysis. In older children above 5 years of age, these vessels regress completely and the physis functions as an effective barrier, confining osteomyelitis to the metaphysis. This anatomical difference has important clinical consequences. Infants are at higher risk for growth plate damage, avascular necrosis of the epiphysis, and combined osteomyelitis plus septic arthritis. Understanding this vascular regression pattern explains the age-specific complications and informs imaging interpretation in young children. Case 10. A 6-year-old girl presents to the emergency department with 4 days of right lower leg pain and refusal to bear weight. Her temperature is 38.8 degrees Celsius. Physical examination reveals localized tenderness over the proximal tibia with mild swelling but no redness. No trauma is reported. The child appears uncomfortable but not toxic. What is the most appropriate first-line imaging study? Option A. Plain radiograph of the tibia. Option B. Magnetic resonance imaging with gadolinium contrast. Option C. Computed tomography scan of the lower leg. Option D. Bone scan using scintigraphy. The correct answer is option A. Plain radiograph of the tibia. Despite its low sensitivity for early osteomyelitis, plain radiography remains the standard first-line imaging study because it is cost-effective, universally available, and rapidly performed. Its primary role is to exclude fractures, periosteal reactions from other causes, and bony tumors that may mimic infection. In the first 7 to 14 days of osteomyelitis, the plain film is typically normal or shows only subtle soft tissue swelling. Bony changes such as lytic lesions and periosteal elevation only appear after this window. A normal radiograph should never reassure the clinician when the history and examination suggest osteomyelitis. Magnetic resonance imaging is then the appropriate next step. Case 11. An 8-year-old girl presents with 4 days of progressive right thigh pain and limping. She has a low-grade fever and refuses to bear weight on the affected leg. Physical examination reveals localized tenderness over the mid-femur with no obvious swelling or redness. Laboratory studies show an elevated C-reactive protein of 8.5 milligrams per deciliter with a normal white blood cell count. Which imaging modality is considered the gold standard for early detection and evaluation of pediatric osteomyelitis? Option A. Plain radiography. Option B. Computed tomography scan. Option C. Magnetic resonance imaging. Option D, nuclear medicine bone scan. The correct answer is option C, magnetic resonance imaging with contrast. Magnetic resonance imaging is the gold standard for diagnosing early osteomyelitis in children with a sensitivity of 95 to 99% and specificity of 85 to 95%. It detects early bone marrow edema changes 3 to 5 days before any abnormality appears on plain radiographs. T1. Weighted images show low signal in infected marrow, while T2. Weighted images show bright signal due to edema. Gadolinium contrast enhancement identifies abscesses, necrotic bone, and subperiosteal collections that require surgical intervention. It also provides excellent soft tissue detail to differentiate cellulitis from deep space infection. Magnetic resonance imaging is therefore essential for surgical planning in complicated cases. Case 12. A 6-year-old girl presents with 5 days of persistent left thigh pain and fever. She received 72 hours of intravenous vancomycin but shows minimal clinical improvement. Blood cultures remain negative. Magnetic resonance imaging reveals a large fluid collection in the femoral metaphysis with surrounding bone marrow edema. Which of the following is the best indication for performing bone aspiration in this case? Option A. Blood cultures are negative. Option B. The patient has persistent fever. Option C. Failure to improve after 72 hours of appropriate antibiotics. Option D. Magnetic resonance imaging shows bone marrow edema. The correct answer is option C. Failure to improve after 72 hours of appropriate intravenous antibiotics. According to the Infectious Diseases Society of America and Pediatric Infectious Diseases Society guidelines, bone aspiration and surgical drainage are indicated when a child does not show clinical improvement despite adequate antibiotic therapy for at least 72 hours. The goals of aspiration are to obtain material for culture and sensitivity testing to confirm the diagnosis and to decompress any subperiosteal or intraosseous abscess. Negative blood cultures alone are not an indication because most osteomyelitis is treated empirically based on clinical findings. Bone marrow edema on magnetic resonance imaging is expected and does not by itself mandate aspiration. Persistent fever with imaging evidence of abscess formation is the clearest combined indication. Case 13. A 6-year-old girl with acute osteomyelitis of the right femur has been receiving intravenous clindamycin for 5 days. She is now afebrile and walking with minimal pain. Her physician wants to monitor her response to treatment objectively. Which laboratory test is most useful for monitoring response to antibiotic therapy in pediatric osteomyelitis? Option A, white blood cell count. Option B, erythrocyte sedimentation rate. Option C, C-reactive protein. Option D, procalcitonin. The correct answer is option C, C-reactive protein. C-reactive protein is the preferred biomarker for monitoring treatment response in osteomyelitis because of its rapid kinetics and reliable correlation with clinical improvement. C-reactive protein rises within 6 to 8 hours of infection onset and normalizes within 3 to 7 days of effective antibiotic therapy. The key clinical rule is that a C-reactive protein that fails to decline by 50% within 48 to 72 hours of starting treatment strongly suggests treatment failure, antibiotic resistance, or developing complications such as abscess. In contrast, the erythrocyte sedimentation rate is a slow-reacting acute phase reactant that may remain elevated for weeks to months even after the infection has been fully eradicated, making it unreliable for early treatment monitoring. Case 14. A 5-year-old boy presents with 4 days of right leg pain and refusal to bear weight. His temperature is 38.8 degrees Celsius. Examination reveals localized tenderness over the distal femur with no redness. Laboratory results show a white blood cell count of 14,000 per microliter, erythrocyte sedimentation rate of 65 millimeters per hour, and C-reactive protein of 8.5 milligrams per deciliter. Plain radiographs are normal. Your community has a 25% methicillin-resistant Staphylococcus aureus prevalence rate. Which antibiotic regimen is most appropriate for initial empiric therapy? Option A, cefazolin 100 milligrams per kilogram per day intravenously divided every 8 hours. Option B, amoxicillin clavulinate 90 milligrams per kilogram per day orally divided every 12 hours. Option C, clindamycin 40 milligrams per kilogram per day intravenously divided every 8 hours. Option D, vancomycin 60 milligrams per kilogram per day intravenously divided every 6 hours. The correct answer is option D, vancomycin 60 milligrams per kilogram per day intravenously divided every 6 hours. According to the Infectious Diseases Society of America and Pediatric Infectious Diseases Society 2021 guidelines, vancomycin is the preferred first-line empiric therapy when methicillin-resistant Staphylococcus aureus is suspected. This is recommended in any region where the community prevalence of methicillin-resistant Staphylococcus aureus exceeds 10% or when clinical risk factors for resistant infection are present. Cefazolin provides excellent coverage for methicillin-sensitive Staphylococcus aureus but has no activity against methicillin-resistant strains. Clindamycin may be used as an alternative in regions with low clindamycin resistance rates. Renal function and serum vancomycin levels must be monitored closely during therapy. Case 15. A 6-year-old girl with acute osteomyelitis of the right femur has been receiving intravenous vancomycin for 4 days. Blood cultures grew methicillin-sensitive Staphylococcus aureus. She is now afebrile for 36 hours, walking with minimal limping and eating well. Her C-reactive protein has decreased from 8.5 milligrams per deciliter to 3.2 milligrams per deciliter. What is the most appropriate next step in her antibiotic management? Option A. Continue intravenous vancomycin for 2 more weeks. Option B. Switch to oral cephalexin at high dose. Option C. Switch to oral amoxicillin clavulinate. Option D. Discontinue antibiotics since she is improving. The correct answer is option B. Switch to oral cephalexin at high dose. Early transition from intravenous to oral antibiotics is recommended by the Infectious Diseases Society of America and Pediatric Infectious Diseases Society 2021 guidelines once the following criteria are met. The patient is clinically improving, afebrile for more than 24 hours, C-reactive protein is declining from its peak value. The child is tolerating oral medications well, and reliable outpatient follow-up is arranged. Since the cultures confirmed methicillin-sensitive Staphylococcus aureus, oral cephalexin at high doses provides appropriate and bactericidal coverage. Early oral transition reduces catheter-related complications, including infection and thrombosis, while maintaining therapeutic efficacy equivalent to prolonged intravenous therapy. Case 16. A 4-year-old boy with acute osteomyelitis of the left tibia has been hospitalized for 5 days on intravenous antibiotics. He now develops progressive swelling and tenderness in the left calf with pitting edema. Doppler ultrasound reveals a deep vein thrombosis in the left popliteal vein. Which of the following is the most likely underlying mechanism for this complication? Option A. Prolonged bed rest and immobilization. Option B. Catheter-related thrombosis from intravenous access. Option C. Severe bacterial infection with Pantin-Valentine leukocidin-positive Staphylococcus aureus. Option D. Underlying coagulation disorder. The correct answer is option C. Severe bacterial infection with Pantin-Valentine leukocidin-positive Staphylococcus aureus. Deep vein thrombosis is a recognized and serious complication of severe pediatric osteomyelitis, occurring in up to 15% of cases caused by virulent pathogens. Methicillin-resistant Staphylococcus aureus strains carrying the Pantin-Valentine leukocidin toxin are strongly associated with deep vein thrombosis because bacterial toxins activate coagulation pathways and directly damage the vascular endothelium, triggering thrombus formation. Risk factors include age above 8 years, C-reactive protein above 6 milligrams per deciliter, and the need for surgical intervention. The Infectious Diseases Society of America 2021 guidelines recommend active screening for deep vein thrombosis in children with severe osteomyelitis and persistent or worsening symptoms. Clinicians should monitor for calf swelling, warmth, or pain in high-risk cases. Thank you for watching Pediatric Case Review. I want to tell you about our Patreon community, which is called Pediatric Case Review. In this community, all videos are carefully organized by body system, so you can easily find and access every lecture in one convenient place. All presentations used in the videos are also available as downloadable photo slides, so you can read through the cases, review the questions, and practice at your own pace. For full details on how to subscribe and join the community, simply comment below on this post, and we will message you directly with all the information. That brings us to the end of today's lecture on acute osteomyelitis in children. The key takeaways are: early recognition of metaphyseal tenderness and pseudoparalysis saves growth plates. Magnetic resonance imaging is the gold standard for early diagnosis when clinical suspicion is high. C-reactive protein is your best tool for monitoring treatment response. And prompt antibiotic therapy guided by local methicillin-resistant Staphylococcus aureus prevalence prevents life-threatening complications. If you found this lecture helpful, please follow Pediatric Case Review for more expert case-based presentations on pediatric medicine. If you have any questions about osteomyelitis or other musculoskeletal conditions, drop them in the comments below and we will be happy to answer.